Hello friends, this is Dr. Pallavi Ranjan, consultant obstetrician and gynecologist, advanced laparoscopic surgeon. Today we are going to discuss a case diagnostic laparoscopy with tubal patency and myomectomy in a case of primary infertility. Here, as you can see in the picture, we have a normal size uterus with a large fundal fibroid around 5 to 6 centimeters. So first we are going to do a tubal patency for her. She has been married for 8 years now and is primary infertility with PCOD. So you can see how we are holding the tubes and the dye test is positive on the right side. Right, and then we go on the left side. So left side there are congenital sigmoid adhesions, but we are not going to remove them. She is just a case of primary infertility, so we are not going to do any operative procedure apart from myomectomy, which does not require sigmoid removal. So here you can see we are just holding a tube from the serosa so that we don't damage the tube, and then we are going to see for tubal patency. So this tube is also patent. So the fibroid is currently not compressing both the cornues and is above the cornu. So we are going to do the myomectomy after this procedure. So in myomectomy, first what we are going to do is inject vasopressin in the dilution 20 units in 200 ml of normal saline. One can inject around 100 cc of the same solution till there is blanching and whitening of the serosa above the fibroid. So once that is achieved and there are no fluctuations in the vitals of the patient, one can start with cutting the serosa with cold scissors. So we are using the cold scissors and not thermal energy here, because cold scissors help in better tissue healing, and thermal energy, since the patient wants to conceive later and will have a serosa intact, so we don't use thermal energy because that will cause damage and necrosis, might slough off, and will interfere with the vascularity as well. So what we are doing here is cutting the capsule, keeping close to the fibroid. One should know the plane where to enter so that there is minimal bleeding. Once you enter the proper plane, the bleeding becomes less itself. So now my assistant is putting the myoma screw to provide traction to the fibroid, and for the counter traction I am using a grasper in my left hand, giving a counter traction and then separating the fibroid from the capsule. We cut the fibroid in bits and pieces, step by step, and don't hurry in giving too much traction. It might avulse or cause unnecessary bleeding. So always give traction, counter traction, and try to separate the fibroids. As you can see, there is no bleeding right now because of two reasons. First, we are in the right plane. Second, because we have used vasopressin to prevent this bleeding and prevent the damaging of our field. So the fibroid is almost removed, 80%, and nearly the bed is. So now you can see I have shifted the myoma in my hand, and now my assistant is giving counter traction. So you have to do this traction and counter traction for the whole process, because it helps in delineating the fibroid and removing the fibroid clearly. In this case, I am pretty sure that I am not entering the endometrial cavity, because the fibroid is a fundal fibroid and is in the myometrium. As per the ultrasound, it is not invading up to the endometrium or distorting the endometrium as such. So here you can see I have cut the fibroid completely from the base and separated. There is very less bleeding. Since it's a laparoscopic view, you can see it in a magnified form, but in actually this is very less. But any active bleeders have to be coagulated with the bipolar. Now we will start approximating the cavity. The cavity has to be approximated in two layers. The basic rule is that you have to obscure any free space to prevent collection of blood and infection. So first we are starting from one angle. We are using Vicryl number 1 round body. One can very well use a barb suture as well, and it is always a good choice to use a barb suture if your patient can afford it. Otherwise use a Vicryl, that is good enough. So we'll do continuous suturing and close the cavity in 2 layers. So now this is the summary of the step. First, inject vasopressin, delineate the fibroid, cut the serosa, separate the capsule from the fibroid. By traction, counter traction, remove the fibroid and do complete suturing of the bed. And then we did an endobag removal after cutting the fibroids in bits and pieces. So this was the complete surgery. Thank you.